In the Aging Positively Reunion Project. It's happening virtually this year, and we have a full day. In fact, coming up at 11:30 this morning, it's Care About Care, everything you need to know about care options, costs, and management, but we're afraid to ask. And then our programming continues at the noon hour with breakout sessions, and of course, a full afternoon of programs as well. But now our next session is a COVID update, panel discussion on the topic that's affecting everyone, as we've already heard about this morning. In some way, shape, or form, we're all being affected by COVID. And today's panel includes 3 speakers. They will each have about 5 minutes, followed by a little interaction between them. We hope to have time for questions, which you can ask for in the chat today. If you have a question, you can certainly put that into the chat to our entire group. So our 3 today, Borrego Health, Dr. Clayton Barbour will be joining us. From Desert AIDS Project, Dr. Tulika Singh, and from Eisenhower Health, we have Dr. Ken Lichtenstein. So first, let's begin with Dr. Clayton Barbour.
So I'd like to thank the organization for inviting me to speak today. Again, I'm speaking on behalf of Borrego Health. Regarding COVID, I'm working from home during this time. I'm hoping to return to the office in the next month as the numbers improve in Riverside County. To give an update of our numbers from Borrego Health has done a little over 21,000 tests in the Riverside County area. Of those, we've had 3,266 positive, for a positive rate of about 15%. What we're probably more concerned about is what's happening with HIV. When some of our data bears out what's been seen in other countries where HIV doesn't seem to be a bigger risk factor for more severe disease. Through our specialty clinic at Stonewall and through our specialty clinic in Desert Hot Springs, we've done approximately 644 tests. There's also other tests we reported that people had done that the county reported back to us, but I'm not including those in this presentation. Of the 644 we've done, we've had 50 positive tests for HIV positive patients. Fortunately, we've had very good results and stuff through our providers, Joe Damon, Rob Fontanilla, Henry Noskvitsky, myself, and Dr. Fagan was with us. We had those 50 patients. Of those patients, only 2 patients ended up being hospitalized. So the majority of our patients recovered and did well at home without not requiring hospitalizations. 1 patient is known to have died from COVID-19. There's a separate patient who did die, but I think it's not related to COVID-19 because he was actually a patient with 73 years old with multiple myeloma, colon cancer, was admitted to the hospital earlier this year with COVID-19, was discharged and was doing poorly as far as his cancer diagnosis and was eventually put into hospice and passed away. But he did seem to recover from COVID-19. The other patient was a 63-year-old with a history of COPD who did pass away. I think our numbers look very good, but the 50 patients, we expect to see a higher number of patients being hospitalized. So I think that's pretty good. So our infection rate's only about 8% of the tests we've done. So we're lower than the other populations. And I think that's partially because our patients, Riverside County has a lot of positive patients because people in the workers working in the agricultural area in Coachella in India had very high rates of infection. So a lot of our patients have been fortunate in that they are able to do more social distancing, stay at home, and plus being HIV positive, many of the patients for many years are more cognizant of their health care and taking more precautions to prevent infection. So we've had a pretty low rate of infection of those patients. We've had close to 1,600 patients. Of those, 644 have been tested. And again, of those 644 tests, we had 50 positive tests with only 1 patient known death, 2 hospitalizations, 1 known death from COVID. So that's pretty good compared to the statistics we've seen in the country in general. I don't know if part of that success is I've been preaching for to patients taking vitamin D for many years. I've known for years some of the HIV medications do lower vitamin D levels. So we're monitoring that for many years. And all of our patients, the 50 patients who tested positive, 48 of those 50 all had normal vitamin D levels. Normal for that is between 30 to 100. Our patients, the positive patients, had average level between 40 to 60 for their vitamin D level. So whether that's part of the difference, I know vitamin D has been shown in several studies in the past to minimize the severity of flu. And there's some data suggests it minimizes the severity of COVID-19. Again, it doesn't prevent the flu, it doesn't prevent COVID-19, but it may minimize the severity. So that's what I have to say. I think my time's up, and I'll leave it back to Jeff.
All right, thank you very much, Dr. Barbour. And now we will move on to Tulika Singh, who's the Associate Chief Medical Officer and Director of Research at Desert AIDS Project. And we'll get switched over to her, and we'll be right with you.
Good morning, everyone. It's nice to see so many familiar and unfamiliar faces here. Thank you, Jeff, for organizing this and inviting DAP to be part of this. So, you know, Dr. Barbour gave a wonderful review of how Borrego Health, which is, by the way, great job, Borrego Health, in, you know, curbing down the impact of COVID in the Valley. We really appreciate that. I mean, this pandemic, like I keep saying, is for everyone, and it's up to all of us to help each other and the community to curb this pandemic. So at DAP, as you all know, and some of you, if you don't, we started our COVID clinic, which was dedicated to COVID-related services mid-March. It happened actually overnight. Suddenly, you know, one of our ID clinicians and I, myself, Dr. Gakar, were 3 ID physicians in DAP, just suddenly thought that maybe we should dedicate a clinic at DAP just for COVID to separate possibly infected and affected people, patients with COVID from the rest of the general population in case we have to shut down or have to continue services. So that was the idea behind the inception of the COVID clinic. Dr. Chris Scholes was the lead clinician in spearheading this project. He did a wonderful job. Recently, he returned back to his primary care practice at DAP in the Blue Clinic. And I wanted to use this opportunity to thank him for his amazing, you know, creativity and inception from the get-go. He was dedicated for COVID medicine for the last 6 months, partially doing his clinic as well, but now he's back full time. So with that, you know, mid-March through mid-October, right? So we have been doing this for 7 months now. And we initially were doing symptomatic patients. We were checking their PCRs. Later on, we got the machine to do antibody testing, which was testing IgG and IgM antibodies. And, you know, we have also processed, I don't know the exact number like Dr. Barbour knew about the thousands of patients that they have done the tests for, but ours are also in thousands, maybe not to that degree. But of those thousands of tests that we did, we saw less positivity rate than Borrego Health did. And we, you know, have had so far 250 positive cases. Now, as you know, the Riverside County, who is also on our own campus at DAP, was also offering the same testing. And so some of the patients have gone through that, you know, center, and some of them went through us. That might lead to some difference in the census. But overall, we saw, you know, curves. You know, initially there was March, April, there was a peak in the COVID cases, and then June it went down, and then July we saw the surge again, and then it went down again. And we were beginning to see the surges that we saw were usually after the community opened up a little bit, businesses opened up. After holidays, we saw the surges, as in rest of the country. So overall at DAP, we have had 250 positive cases, like I mentioned, and then I would like to divvy them up based on gender, based on person living with HIV versus non-POS, and based on age. So I will go with the first, there's a definite male predominance in our positive cases. Of the 250 cases we found positive, 171 were males. So 69% of those 250 cases were male. Females were 79 out of 250, which makes it for 31% of cases. So basically 2/3 male, 1/3 female. And then person living with HIV, we're seeing, just like rest of the community and the nation and internationally too, there were only 37 positive COVID cases who were also person living with HIV. So that makes it up to 15% of all our positive cases are also person living with HIV. 85% are non-pos. And we're seeing this in inpatient setting too. Dr. Kakar, alerts us of inpatient data, and they have seen very few cases inpatient as well. Age-wise, we have seen, initially the risk factor, age is an independent risk factor for getting COVID, but for the testing as well as how many positives we saw, are actually age over 65-year-old positive patients only make up to about 15% of positive cases. So only 39 patients of those 250 positives are older patients. 85% of them are younger patients. So again, we saw a little bit difference in what we're seeing internationally. Our patients are younger in the Valley who are getting COVID. Now, if you combine person living with HIV and older patients over 65 years old, we have total 4 positive cases in that combination. So makes up about 2% of our 250 cases that were not only COVID positive, but also person living with HIV and over 65. So, the fear that older HIV patients are gonna get more COVID, we're not seeing that. I think I agree with Dr. Barbour that vitamin D supplementation, our Valley is very blessed with a lot of sunshine. So as compared to Michigan, where I came from in 2017 to DAP here, I definitely see higher vitamin D levels. But surprisingly, I do see a lot of low vitamin D levels when we check in our patients too. And most of our patients are on vitamin D supplementation who need it and who are low. I personally take vitamin D. I was low, well, in my Michigan history, I guess. And I personally take vitamin D, zinc, as well as vitamin C during the cold season. They're shown to be a protective barrier that vitamin C and zinc can create in your mouth so that the virus doesn't attach to the mucosa. That has some protective effect. So overall, we're continuing our COVID curbing efforts. I'm very excited about the vaccine coming out, hopefully later this year or early next year. We're very, very pro-vaccinating for influenza. We have influenza clinics starting soon. We have vaccinated all our employees and vaccinated most of our patients. Best time to get vaccinated for influenza is now. So please go ahead and vaccinate for influenza as much as possible. And then when the COVID vaccine comes out, it's coming out in 4 different waves. So frontline clinicians, including physicians and nurses, and our front desk staff will get the first dibs on the COVID vaccine, as well as patients who are high risk. That will include person living with HIV. So please get vaccinated. It's the only form of a real, immunity that we will have to develop, along with masking, physical distancing, hand washing. Even face shields are very important to protect your eyes from it. Our patients, person living with HIV community has done a great job with doing these precautions. And that is one of the reasons I really feel is responsible for such beautiful low rates of COVID positivity in the community. And with that, I'll end it, and happy to answer questions in the Q&A session. Feel free to send your chat questions to me personally, as well as on the platform. Thank you so much for having me. Have a great day, everyone.
Dr. Singh, thank you so much today. We really appreciate your time. There are a couple of questions in the chat, so we may want to ask you to maybe answer a couple of those. during our next presenter, which from Eisenhower Health here on the main campus, we have Dr. Ken Lichtenstein.
Hi, everyone. What we are looking to do at Eisenhower is get involved in some research. So I wanted to talk a little bit about what we've done and where we are heading with additional studies. If we could go back to that first one, leronlimab was a monoclonal antibody. Some of you may be familiar with it. It's the same compound that was used for HIV in a number of studies called Pro-140. This study was done at Palm Tree Research and at Eisenhower. And what we found, the study is complete. I say full results are pending, but I can tell you that the results were not, they were beneficial, but minimally beneficial with that particular compound. Next slide. So we're also about to start a remdesivir study. Remdesivir, as you know, has been used on a compassionate use basis in people who are hospitalized. This is an ambulatory study in people with mild to moderate disease. It will be a placebo-controlled trial, which is good science. And you can see that it has to do with people who've had symptoms for 7 or fewer days after they've been tested. Oxygen saturation has to be above 94%. This is 3 daily intravenous infusions. We will be beginning enrollment in the next week or two. This is remdesivir is sponsored by Gilead. If we can move on to the next. The ACTIVE-2 trial is actually an NIH sponsored trial. It's called an adaptive platform, which means we can look at multiple candidate drugs in phase 2 and phase 3 studies. So we can have multiple people on multiple different drugs as we're doing the study. It allows us to, it's part of Operation Warp Speed in the sense that it's trying to move things along, but obviously paying attention to the science. This again is an ambulatory study in people with mild to moderate disease. The first agent we're looking at is a monoclonal antibody that's a Lilly product. I should point out that the president did receive this. This wasn't part of that cocktail, but it was an additional drug that he received. The way it works is it's a monoclonal antibody against the spike protein on the virus, and it prevents the virus from being able to attach to the cells of an individual. Again, this is a single IV infusion, and that's all. There are multiple visits, obviously, in follow-up, but it's a single IV infusion. We will be starting enrollment again in the next week or two. And again, this is the National Institute of Health, specifically National Institute of Allergy and Infectious Diseases, which is Tony Fauci's group. And finally, the last slide, we are in discussions with the NIH as well regarding an adaptive platform to study at least 5 candidate vaccines, again, part of Operation Warp Speed. So if there are any questions, obviously, I'll be happy to respond.
Yes, one question that did come up. What does the word monoclonal mean when you talk about monoclonal antibodies?
Monoclonal means it's a very specific antibody that's directed at a specific protein in the body, in this case, and in this case, it's the spike protein of the virus. So it acts like a normal immune antibody would against the virus.
All right, thank you very much. Dr. Lichtenstein, Dr. Singh, and Dr. Barbour today talking to us about some of the latest research that's going on and where we are. And I think what I find the most interesting about this is we hear about this on the nightly news in very abstract national, international terms. And now to have this brought down to our level, to know exactly what's going on in the various trials, et cetera, I think is very reassuring for many of us, as well as very informative today. So I thank you very much for that presentation. We are on time this morning, which is wonderful. So it is just after 10:30 in the morning, and we are on to our next session.